That is actually what the Commission has done, and we are also intending to go further than that. Thank you.
Thank you, Mheshimiwa Jaji, for your intervention. And I really appreciate. I got a bit worried when you started using the word procure. Procuring abortion, it sounds like very scary, I would rather use the word seek abortion services rather than procuring abortion. But I want to go to Dr. Makwani. So, Dr. Makwani, when we look at the Maputo Protocol, the section that we are discussing today is all about, sexual reproductive health and rights, And within the government of Tanzania, you are a person who is responsible for ensuring that, sexual and reproductive and rights, are being availed, within our public and private health systems. Now, when I look at what the chairman has said from the commission, it looks like the commission is doing a lot of work around this SRHR. So my question to you, Dr. Makwani, to what extent, or to what extent is you or your teams involved in these discussions? Are you communicating with the commission? Is the commission communicating with you? Are they seeking advice from you? And if they do, what advice are you giving to them? Karibu, Dr. Makwani.
Thank you, Mr. Dr. Komwangiro. And thank you, Judge, for that very elaborative legal point of view of the issues of Maputo Protocol, particularly when it comes to provision of services related to unsafe abortion. I would say that I think much more we have worked so much as a government, we have worked so much in terms of trying to expand this legal framework. And pulling together, you said the Section 230 was too far. And there's another one, which is Section 219, which talks about child destruction. What we did, we brought all these sections together in a guideline. So that because when you look at, globally, when you look at the sections, fairly for a provider, it was extremely difficult to translate them. So to enable the provider to translate these sections, that means section 150, 151, 152, and then going to child destruction section 219 and 230, whereby it gives some room in situations where you can give a service to a woman to terminate a pregnancy. These, it is true, they were too far, and to make them more practical, we produced a guideline. The first guideline was in 2015. The second version of the guideline was 2020. And why did we make this guideline? Possibly that answers the question for the Maputo Protocol. We made these two guidelines to enable the provider to know exactly where they can give a service to a woman to terminate pregnancy, especially when it says the pregnancy is endangering the life of that woman. We expanded that guideline. And there were so many questions and there were so many myths among healthcare providers. They were saying, in order to give this service, you need to be 3 of them. But when we brought lawyers, and these were lawyers from the government, they said, that is the obstruction of service. And I could hear the lady lawyer saying, it is an obstruction of service, saying that you need a concession of 3 lawyers. You need this one. And we wanted to use doctors. He said, no, that is an obstruction of service. You need to say a competent, skilled health worker. So we have expanded these sections to make easy interpretation of the providers. But again, we went further. The guideline has evolved with the technology. The guideline, which was made in 2015, limited itself to the use of MVA. And we know MVA, although we have brought it so that it can be used within the legal framework, but it falls into the hands of those people who misuses it. And I remember one person said, I sterilize it using a 70% spirit. That means this person was likely transmitting other communicable infections. We evolved with that technology. We brought in misoprostol. The current guideline carries a misoprostol. Why did we bring misoprostol? First of all, we have limited scope of availability of skilled personnel when you go down the ladder to the healthcare system, to the dispensary. It's hardly you can find in some of the dispensaries if you have a CEO. So for that reason, we said we need to give a technology that can give service to these very, very remote areas. I remember one of the story, a woman died in Ukerewe because she was traveling from one island to Nansio to get post-abortion care services. On the way, she succumbed with the hemorrhage. She died in. If that facility, if that community had misoprostol, and if that misoprostol was given to this woman, likely she could have survived. And the guideline has addressed that. Secondly, there is a challenge whereby the environment where the MVA is performed for those people who have an abortion, the environment is not conducive and you cannot guarantee on issues of infection. We said we needed to bring the technology which will not cause an infection. We brought medical. The guideline did that. Thirdly, when you go to these facilities, you find when they are helping this woman, she is 100% naked. I remember I visited one of the facilities. I was almost, as a doctor, most likely I was running away. She was completely naked. We said, no, we needed to bring compassionate care that cares the confidentiality of a woman. We brought the technology whereby you not necessarily you'll make that woman naked. And fifth, there is a problem when you do surgical procedures, you do it under pole. We said we wanted to remove that under pole because we don't think it is very painful. It is painful, but women try to tolerate it. But it is very painful. We said we wanted to bring technology. Misoprostol was brought on board. How much didn't we touch the Maputo protocol? I think we addressed the full strength of the Maputo protocol. I submit.
Thank you. Thank you, Dr. Makuani, for your intervention. Now I'm going to go straight to Dada Tike. Microphone, please. Can someone help to take the microphone to Advocate Tike? I really appreciate your interventions, Dr. Makuani, and for elaborating actually what the government is thinking and what the government is doing. But now, Tike, you are the chair or the coordinator of CAMMAC. So maybe my question should start with, if you can spend 2-3 minutes to tell us what CAMMAC is, and also tell us what CAMMAC has been doing, especially in this area of sexual reproductive health and rights. Karibu, Dada Tike.
For you to know that you're a Tanzanian, you have to do this. Yeah, so I have two things before I answer the question. I have two things that I'm celebrating today, this afternoon. One, amongst us, we have the just appointed African WHO director in this room. And being a Tanzanian, I am very much proud and happy. And the fact that he's my MP representing Kigamboni. So thank you very much for attending, and we appreciate that, and congratulations. And the second thing is when we started CAMMAC in 2010, we never had this kind of conversation. So this is something that I'm celebrating. Being amongst you people and having representative from the government taking part in this conversation, for me as a chair of CAMMAC, I am very much excited because it was not possible when we started. We all know, being Tanzanians, even Africans, the topic is not something, it's not fancy. It is not something that someone can come and have this kind of conversation. So when CAMMAC started, we were named. We were like, you're bringing vitu vya Wamarekani, mnabreta vitu vya wazungu, you are bringing European, conversations, you have better things to discuss. And yet people are forgetting a lot of young girls, and even we, the women, are dying because of unsafe abortion. Because we have our cultures, how we do it. You tell me in our communities, how many people you know in your community who either died or almost died because of unsafe abortion? I know majority of us, you raise your hands. So this is something that it is very important for us to have this kind of conversation. So at the beginning, we hosted a meeting and we had so many people who wanted to become members of CAMMAC. But now, when the opposition came, we remain, I think, 10 now. We are 10 or almost 13, 15. Yeah? Now we're moving to, now from this year, things are becoming better. So I would say from like last year or 2 years back, we were 13 or 10. And even some of the members who were expecting that they will give us support or they will be key, some of them left. I won't mention name, but they left. So we remained. And the good thing with CAMMAC, the way, the composition or the membership, it has the international one and us, the local. But then we have those who are practicing and non-practicing. There are lawyers like myself who don't know those, those languages, the medical languages, the hemo, whatever that we're learning. And then we have the doctors, we have the nurses, we have the social welfare officers, and we have even, everybody, we wanted them to be on board. Why? Because this is an issue that needs everybody effort. Everybody, we need to have everyone together so that when we discuss these things, everyone is aware of what is going on. So as the lawyers, we are bringing our legal languages in some of the documents, and the doctors, they know their issues, and the people from the community, they can come and tell us and share their experiences in the community. So what have we been doing for the past, I would say, almost 14 years? What we've been doing, the first thing that we did was first to equip ourselves with knowledge, with value clarification, because this is an issue that the issue of unsafe abortion is about the value clarification, because you have to understand so that when you go out, you are able to communicate better because you know and you have the information. And after that, we came up with different strategies. At some point, we developed an alternative bill, Safe Motherhood Bill, of which it backfired at some point. Why? Because we had put a component of termination of pregnancy. But to us, much as I'm saying it backfired, but it was also a blessing in disguise. That's when now the conversation of, about the post-abortion care came forward. And now that we are now post-abortion care, it's there, it exists. Although, for me, I would say, why post-abortion care? So you allow someone to go and do abortion, and then you go and treat. So that's something that we are doing. We are having this kind of conversation, and I'm happy that now we have people from the government on board, and we're having this kind of conversation. And then, now we are also doing awareness to the community about the implication, about the dangers, because I think if people lack information, I think information is power. So what is needed, and at times someone may not procure, he said we shouldn't use the word procure. Someone may not need to do abortion, yeah? The only thing that sometimes make people do so, because they lack information. And now that there's MISO, there is, the services are available, post-abortion care, and all that. So people need to have proper information. And I'm happy that majority of the organizations that we are working together are doing the awareness to the communities, but at the same time, we also had to engage healthcare providers and even training them on so many issues. And at some point, we're like, okay, why not open a case just for testing in our local courts to see whether, because again, there are times, there are issues that are happening, sometimes it's because of negligence. And at some point we wanted to test, but we didn't. But I know we are planning, or we already opened a case. My colleague is going to talk about that later on. But we have been doing a lot of stuff. But what I can say in summary, for us as CAMMAC, we're inviting a lot of organizations to be part of this coalition, because at the end of the day, we want to save the girls, we want to save us, the women, because if we are not healthy, if we are not getting the services, I know this is one thing, there are so many things that maybe us, the women, need, but at least if we're able to get this one, yeah, and you know that under Maputo protocol, as much as we are talking about the health of the mother, but then the conversation about rape, if someone is raped, you walk with that pregnancy for 9 months. Really? I think we need to do this kind of conversation. And us as CAMMAC, we are not saying, this is my body, I can do whatever I want to do. We are not yet there, and our values are not allowing us to do that. But in such kind of environment, let's allow, yeah? Let's allow safe abortion. And people, at the end of the day, we are going to have a community that is very happy, and all of us are going to enjoy our lives, knowing that, our health is in better hands. And once again, I appreciate the members from the government for being part of this kind of conversation.
Asante sana, Mheshimiwa Msomi, Advocate Tike. It sounds completely different when a woman is speaking about women issues than when a man is speaking about women issues. And I'm going to go to another woman, Dada Walter. Dada Tike, when you were speaking, you mentioned about testing the waters, opening a case. And you said some initiatives have already started. So I'm going to ask Walter if you can share with us a little bit about what is it that you are doing, what is it that CAMMAC has done, what is happening there in the legal system.
Okay, thank you so much. With regard to that question, actually at CAMMAC, we have initiated one of the strategy that are almost have been used by other countries in Africa that are assisting in amending the laws. So just to mention this kind of strategies, strategic litigation, filing of strategic litigation case. So for the purpose of other people in this room who are not lawyers, when I say strategic litigation, I mean we call it, in a simple language, it's an impact litigation. In Kiswahili, we call it kesi mkakati, which is one of the strategy that one person or a group of people can file before the court of law to seek for the amendment of the laws. So actually, it's not a case that you sue the government, but it's for the purpose of seeking for the amendment of the law due to the breach of human rights. Basically, we are challenging the violation of the basic rights and duties under the Constitution. For the purpose of our Constitution of Tanzania, these basic rights of duties, you can find them and from Article 12 to 29. So because this thing is concerned with the women, so it's directly we touch the issues of health and even life of the women, because when I'm referring to the first panel, Honorable Mwaim, he mentioned about the exception to the general rule at the penal code that we have under section 230, that is to save the life of the women. So because the life of the women have been touched, and CAMMAC is still addressing the issues of reducing maternal mortality. And when we say maternal mortality, we touch the life of women. So through that is where we went there to challenge that violation of human rights. And we used that strategies because we have seen some of the improvements from other countries, but not only in other countries, even in our country. For those who can remember, there is this very famous case of Rebecca Gyumi from Msichana Initiatives. It's one among the cases that have been used, one of the article from Maputo Protocol, Article 6, to challenge the age of marriage. And they filed this kind of case at the High Court of Tanzania in 2016. And also the courts ruled in favor of the Rebecca Gyumi, although the government have been, they appealed, but also even during the appeal, they still won. And now there is an ongoing movement to influence the amendment of the law as directed by the court. But apart from that, we opt to use strategic litigation strategy. It's because we saw some of the few African countries who have been succeed, or there is an ongoing improvement that have been resulted from strategic litigation case. And I'll use 2 examples from Kenya and Malawi. Like in Malawi, there is a very famous case of Nachingwe's case, whereby they challenged it to the High Court of Malawi to challenge the restrictive laws that was denying the access to safe and legal abortion for the survivors of rape, incest, and sexual assault. And mind you, here we are not advocating for the access to safe and legal abortion for all people, but specifically, we want the implementation of the Article 14(2)(c) of Maputo Protocol that expands grounds for the safe and legal abortion to the victims of rape, incest, and sexual assault. So for this case of Malawi, of Nachingwe's case, they challenged these restrictive laws in Malawi under their penal code because we share the same legal system, because even their penal codes, they also allow abortion just to save the life of the woman. I think it's medical reasons. The same applies to Kenya. There is one case that have been filed by the Federation of Women Association of Kenya. They also challenged the High Court of Kenya because they withdraw the safe and legal abortion guideline. That's it, basing to the government, they were in demand that this kind of guideline was influencing people to do that abortion. But in this case, they also won, and even the guideline that have been withdrawn, it has been reinstated. So for us as CAMMAC, we try to use that strategy of strategic litigation.
Thank you. That's very interesting. You know, we are learning new words. Strategic litigation, kesi mkakati. Before I take away the microphone from you, do you think Tanzania is ready for that? And maybe what challenges are you anticipating ahead in pursuing that?
Okay. Yeah, so I can say is is ready for that, but what we need is public support. Like, I can give you a good example of the first case that I mentioned of the Rebecca Giumi case. One of the things that is lagging behind up to this moment, it's because it still lacks the public support due to cultural issues and traditional issues and even religious. So challenges are there because many people, they do lack awareness about that. But basing on the vivid examples, as I hope even the audience here, they can be, I think they always see in the social media, nowadays there is a number of cases of young girls who are being raped by their fathers, their brothers, their close blood related, that cause even pregnancies. And most of these cases, they are not going to the courts. They are just finishing it at home. So, and many of them, they resulted into unsafe abortion due to the shame of the community and all that. So I think if we'll be having the awareness, everything will be good. Okay. And also, another challenge, there is this issue of stigma. We are living in a community where there is a stigma around abortion issues. So you can imagine, or you can be in the shoes of that woman who have been raped and got pregnant, and she's not ready to keep that pregnancy. If it was you, what could you do? So if you could ask yourself such kind of question, you can see how other women are suffering on that. Yeah. So,
thank you. I'm going to take a microphone away from you, and I would like to take the microphone to Dr. Makwani again. And Dr. Makwani, I'm going to ask you the same question that I just asked my sister there. She has explained about strategic litigation. She has cited some of the examples in Tanzania and beyond. Dr. Makwani, do you think Tanzania is ready? And when you are responding to that, you explained how Tanzania has expanded, the sexual reproductive health and rights and post-abortion care. Should we be expecting more expansion based on the Maputo Protocol? So if you can talk briefly about those two issues, I would appreciate, because I want to give time to the audience as well to ask questions. Okay. Karibu, Dr. Makwani.
I think I'll approach it differently. I would say the Section 230, it includes all those exceptions she's talking about. And what I'm afraid, if they become successful, is like they are closing a door. For example, she talks on issues of rape and so forth. How about if our technology would allow us to detect things like abnormalities for the fetuses? Because the way it is, CAP 230, it helps you to address such things. But when you specify specific issues, it is like you close a door, you close a room, whereby you say, you limit the doctor saying, these are the only exceptionals you can take on board. While when you look at the penal code 230, it is so wide that it is only the physician who decides what to do in different scenarios. So I would say the way they are approaching it, I don't think it is in favor of the practice. Possibly it is in favor of the legal side, but in practice is essentially you are closing the door. The other area that I wished I could touch on was an issue, just to enlighten the fact that issues of abortion, they are very contentious. Currently, there is a major agenda in America in terms of their election. The Republicans, they are saying no to abortion, while the Democrats are saying, if you allow us to hold the office, yes to the abortion. They are not easy. You can discuss it so easy. And they are extremely, extremely difficult. And for me, I would say that even those countries that have ratified abortion, when you look at their law, our neighbor, for example, Zambia, when you look at their law, you find that there is a lot of obstruction. Where are you going to get the gynecologists to ratify in a situation like our developing countries? You are saying you want to get a legal authorization. Where are you going to get a legal authorization? In our piece of penal codes, 230, it is only you, qualified medical personnel, who makes a decision. So some of the decisions, the legal has tried to give us a room so that you can help women when there is a life-threatening condition. But when we want to change such things, we may be creating challenges to get services, especially when we have life-threatening conditions. I submit.
Thank you, Dr. Makwan. So this is a different perspective. You know, the lawyers are saying, let's go for it. You know, kesi mkakati. The health sector is saying, be careful. You may end up blocking the services. Mheshimiwa Jaji, wewe unasemaje?
Yeah, I think we have a situation where we have various players. Where you have the legal fraternity who are, of course, would like to see the provisions well crafted to entertain those specific areas in accordance with the Maputo Protocol. But you have health practitioners like what Doctor said here. In my case, I would like to say that it is, first of all, let me say that in this symposium, I've learned something from Dr. Makwani. You asked him a question whether we are communicating. I think we are not. I will say that. We are not communicating openly to discuss those issues. Otherwise, he has raised very pertinent issues here about the guidelines which have been prepared by the health institution in order to address those challenges. To me, I will say those are very good, and actually they are really addressing those issues. But when you go to the context of law, I will say maybe those guidelines may be turned into, brought into the law. Because if you put them in law, it will be easy for somebody to challenge if there is any problem arising. And guidelines, as I know, maybe are made for the few. It is not easy for the public to know. Maybe if in symposiums like this one, this could have been one of the topics which have been disseminated to the participants, that would help and may lead to suppress at least the pressure which is hanging around. But yet, I would say to have a law as well is very important, because it helps for anybody. Actually, it protects the legal the health practitioners who might come across some challenges in the due course when conducting these abortions sessions. So to me, I would say all thematic areas, the legal fraternity, the health industry, all of them are important in this aspect, as well as other stakeholders. I would say that this is a joint effort. All of us have our specific areas of concentration, and all of us are supposed to be put together so as to come with solutions which will help to improve the situation on the ground. As I started earlier, I said that there are those exceptions to the general rule. And the general rule is intended to protect the right to life, as I have said. So those exceptions, I will buy the idea by Dr. Makwani that sometimes when you want to specify things in laws, you might end up trying to close the doors on those areas which might be contentious. So sometimes the law is a living document. When we're talking about law, laws are living, so they can be changed at any time. But when you construct a provision widely, you have a better opportunity to bring on board other situations. Because when you go to the court, the role of the court is to interpret the law. So in many cases where if you place things which are straightforward in that, when other situations arise, unless you come with the principle of use them generis, that you say those who are in the law are more or less similar to those situations which arise which are not in law. If you come with that principle, maybe you can, the court can interpret in that way. So to me, I would say that this is a joint effort. I will not deny the steps taken, the strategy taken by our colleagues, or by having what we call this strategic litigation.
Yeah.
And also, I will accept what Dr. Makwane has said on the guidelines.
Yeah.
Only that I will feel comfortable if those guidelines can be embodied in the laws.
Mheshimiwa, I will take the microphone from you. I can see that Tike wants to say something, and she's very eager about it. But Tike, when you are speaking, remember you have two hats. You have the CAMMAC hat, and you have the Taula hat. So before you speak, tell us which hat you are wearing, and please be brief because we want to have questions from the floor. We still have like 15 more minutes to go. So, yeah, Karibu.
Yeah, I'm wearing both hats.
Please, the microphone closer.
Thank you so much, Judge. You've said whatever I wanted to say. That's all I can say now.
That's it?
He said it. I don't want to add anything. I'll remove anything. No.
And that
He
is the
said
Taula
everything.
hat or the CAMMAC
Both
hat?
CAMMAC and Taula, because CAMMAC is what we've been advocating for so many years. Yeah, to have provisions in the laws that whatever that is in the Maputo Protocol to be included in our laws. That is something that we've been trying to do advocacy, and hearing from the commissioner, speaking it, saying it, it is adding my excitement as a chair of CAMMAC. So today I'm just here so much excited, and I'm sure some of the colleagues from CAMMAC are also very much excited.
Okay.
Because this is something that we really wanted to hear from someone from the chair of Chirag, but also from the Minister of Health.
So for me, I want to be a devil's advocate. Why don't we meet in the middle? So we say in Tanzania, abortion can be provided during life-threatening conditions, including rape, incest, sexual assault, etc. And then that etc. opens the doors for any other things which may come. So in that way, we have become specific to the doctors and nurses, but at the same time, we have opened the doors for other issues that may emerge. What do you comment, Dada Tike, on that? Why don't we meet in the middle? I don't know.
I don't know. I think the focus is Maputo protocol. And with Maputo protocol, as much as there is extra, but again, I remember the conversation around the health of the mother. Sometimes it was very confusing at some point to define it. When you want to say, okay, if the health of the mother is in danger, how do you define it? And sometimes we would ask that question to the doctors. Sometimes they didn't have answers. And some of the doctors, they will go back to their beliefs, religious beliefs, and they will not allow to do that. So for me, I would think, let us be specific with the agenda that we are asking. And then Judge and the chair of SRHR, he's put it very well. The law is a living document. So if there will be anything along the way that needs some sort of amendment in the law, then we can work on it. But we are having this conversation, and CAMMAC, we are open to advise, to, you know, we are very much open because it's been a learning experience the first 14 years. So if we will decide as CAMMAC when we sit together whether we, you know, what you are proposing, we can go with it, or we maintain what we think that we need to have in our laws.
Asante. So now we are opening the floor for any comments from the audience here. Maswali, comment kwa Kiingereza ni nini? Nukuu. So any comment, any questions from the audience. Naona kuna mkono pale. Kama tungepata wasemaji wawili au watatu, alafu tungerudisha microphone kwa waheshimiwa hapa waka respond. Alafu karibu.
Asante.
Karibu.
Karibu mchana.
Karibu.
I'm Dr. Lipingu from USDF yangu mama na mtoto. And actually I've participated in developing these guidelines where Dr. Makwan has mentioned. Now hearing these discussions, and if this Maputo protocol is not domesticated yet, and those guidelines are out, and the people can read the guidelines and say, according to this condition, abortion is possibly can be done. Now I'm wondering, as Honorable Mwaimu said, we need to put in the laws first. So that means we are not there yet. We need to make sure that the things are in the law. But my question goes to TK. According to a lot of your discussion, you only mention safe abortion, but I don't hear you well mention legal and safe. What I was mentioning legal and safe at the same time, but we are mentioning only safe abortion. And sometimes people can just go to procure abortion for the sake of just termination without any reason. So for you, if somebody comes and she wants abortion without even following the Maputo protocol, would you send somebody for abortion? For example, for family planning, termination without any conditions? Thank you so much.
Thank you. Naomba uje hapa, alafu uende kwa brother pale na kwa dada pale. So, hayo maswali matatu, alafu turudisha microphone hapa, alafu kama tutakuwa na muda tutarudi tena.
Asante. My name is Dr. Caleb Joel. I work with Maria Stops, leading an intervention called Public Sector Strengthening, where we aim at improving the quality of care at the public health facilities. Now my questions goes to Dr. Makwan, whom we work as well together. Looking at the legal context of this issue in our country, there has been a rising up of unsafe abortion, on the other hand, because it's not legally allowed. And in that case, we have a lot of cases which are not reported definitely in the system, data monitoring system, but they are threatening the life of this woman we're speaking about. Now, I know the government have been doing a lot around that area, and as our focus is in improving the quality, we support the government in improving the facilities, infrastructure, as well as capacity of the healthcare providers. But because of the legal framework and context, the providers does not really report these numbers, and the patients are taken to some environments which are not, they can't meet the clinical quality. What are we doing at the government and as well as the legal context to strike a balance between the two and reduce the rate of unsafe abortion? Thank you.
Thank you. Kule nyuma kule kwa brother amesimama pale. Please be brief, go straight to the point so that we can have many more questions. Karibu.
Asante. Kwa jina naitwa Dr. Mugisha Ntionza Nkoronko. I am the President of Medical Association of Tanzania. Nashukuru sana for having this particular forum. First of all, I want to congratulate all of you for at least talking about it. At least talking about it. But number two, I would like to address the issues that I'm seeing. The way you are seated, we will never succeed. There are legals and there are practitioners. We need to come and integrate at the ground level of our citizens and design interventions on how best we can communicate all of the things that have been discussed. Unless we do so, it is when we'll make a step. Number three, I've seen in top zonal referral hospitals, gynecological department, number one, in the top 10 diseases, abortion, it is there. And they are not treating legal abortion. They are treating complications of abortion. I was in Kigoma. If you go in the ward, gynecological ward, they call women ward, you'll find that abortion is number one. I was at Benjamin Mkapa, gynecological ward, abortion number one. So from clinical ground, we are treating complications of abortions. We can't avoid it. We need to find the best way to communicate with our people in our country and address high levels and low levels and come with a conclusion on how best we can move forward. Second and last, it is important that we engage the citizens themselves. And here I'm talking about the education gap between the recipient of these services and the one who are designing policies for them. You can see the assimilation, the interactions at the lower levels is very limited. And if we don't include it in our portfolio, engage them, have them capacitated to demand, to require, we'll just be making noises here and there without making a proper movement. Thank you.
Asante sana. Swali la mwisho kutoka kwa dada yangu pale. Alafu baadaye tutarudisha microphone hapa kwa ajili ya kusikiliza comments za panelists wetu. Karibu sana dada. Welcome.
Asante sana. Good afternoon everyone. My name is Lea Bategereza, research scientist from Ifakara Health Institute. Congratulations so far for a nice panelist and informative session. I'm happy about that. But I want to suggest on something alongside the preparation of the guidelines. You could do the informative research, more specific to the community level, to understand their knowledge and the practice along the abortions, and what do they think about the guidelines that you have prepared. And also, you should also think of the appropriate platforms that you're going to use to disseminate such kind of information so that everyone can be aware of that. Thank you so much.
Asante. Thank you. So please bring the microphone and hand over the microphone to Dada Tike, and then we will come back to Dr. Makuani and Hannah Abujaj. Yeah. So very briefly, Dada Tike, the question which was directed to you.
Okay, I'll start with the last one. Ifakara Health Institute Research, Sindio? Sasa, because you do research, we need you here. So please, what you've just mentioned, please help us do it, so that at the end of the day, we are building the same house, which is Tanzania. So we'll come to you. My colleagues, they saw you, so they will come to you, so that we continue this kind of conversation. And doctor, thank you so much. Yes, even when I was sitting here, I'm like, okay, so the ladies are sitting this side and there. Okay. So, but I think it's by design. It's not like it was, it was planned, no. But again, with CAMMAC, it's not the same. We have this conversation together, all of us as a team. And thank you for reminding us about working with the community. Because if we don't go to the community, we are not doing anything. It is the community that help us to design our advocacy strategy, our awareness programs, and all that. So thank you for that reminder, and I'm sure a majority of us who are doing advocacy, who are doing this kind of work, have had, and even I said earlier, our culture, our values are not, we are not yet there to say that it's my body, I can do whatever I want to do. If I get pregnant today, I should do it. No, 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 no. There must be some sort of value in any community. Maybe later on, the conversation is going to be different. But for now, what we are saying is what our government, our president, and our Ministry of Health have agreed, yeah, at a regional level, where now the case of rape, incest, and assault should be included in our legal document. That's what we've been, that's what we want to see at the end of the day as CAMMAC. So I think those are the issues that I was to address.
So, Dr. Makwani.
First and foremost, I'm happy to have this conversation, and I'm happy also to see Mheshimiwa. Yeah, I know. But there is going to deal with the entire of Africa with the different perspectives. The northern part speaks different language, East Africa speaks different language, SADC speaks different language. So as when you go to ECOWAS, you find different language on these matters. So for him, we could see some diversity right away before taking the office that is going to face. Karibu sana kwenye shughuli. So I would say, first of all, I want to clarify what Dr. Lipingo has commented. We domesticate Maputo Protocol with the reservation. Without reservation. Without reservation. We implemented most of the articles in Maputo Protocol. In 2007, that's when we domesticated it. Tayari.
Dr. Makwani, please.
Then, I would like to comment one issue. This is not my first session on issues of abortion. I've attended several sessions. And I'm happy that you brought this issue of value clarification on board. The question that most of the time I've been asking to my fellow colleagues was, would you like to be labeled as one of the abortionists? Dr. Ngarina, would you like to be labeled, ukitaka abortion pale ndio kigogo? Would you like to be labeled that way? No. Value. So it's not an easy question to untangle. And even South Africa, there was a champion for abortion. He's now late. I've forgotten his name. He pointed out that women still go for abortion in a clandestine environment, simply because they don't want to appear in those clinics and be viewed as they are going to have an abortion. Again, that is an issue of value. In Kenya, I remember one of the organizations collected several fetuses somewhere and they throw them on the road. It was a big topic in the gazette. Na washauri, kama alivyosema hatujafikia hapo. We need to be very careful with our decisions at these stages. Kwa sababu hata wale ambao wameendelea kama Marekani bado wana changamoto kweli. Tena kule with the violence situation ya kule, watu wanauawa, madaktari wanauawa kwenye clinics. Kwa hiyo hili swali sio jepesi kama tunavyoliangalia, ni swali gumu ambalo linahitaji uangalifu mkubwa na tusifanye mwendo wa knee jerk reflex katika kufanya maamuzi.
Asante sana Dr. Makwani. Before I invite Honorable Judge to give his comments about, the questions which were asked, I also want to join my colleagues who have congratulated Dr. Faustin. And Dr. thank you so much for choosing this forum today. And I would like to put you on the spot and ask you to come and say just one or two words, no? Daktari ananifanyia hivi, anasema ataiaddress akitokea Brazzaville. sio sasa hivi. Lakini tunashukuru sana for joining this forum. You know, we know everybody would have loved you to join the forum they are leading. So for you choosing this forum for us is a great honor. So thank you so much. And I think it is a topic which, as Dr. Mapuani said, you are going to be working on in different countries that you are going to be representing. So asante sana for coming here. In these efforts, you know, with CAMMAC and the Ministry of Health, we have been working very closely with the technical people. And technical people who deal with the health of women are AGOTA. And today we are blessed to have the president of AGOTA in the room, and actually also with the president-elect of AGOTA in the room. The previous Honorable Secretary for AGOTA is also in the room. So, kwa upendeleo kabisa, Dr. Ngarina, if you can say one word, Honorable President, before I give the microphone to the judge. And I'm doing that intentionally because the judge will be the last one to speak from the podium. So, karibu sana, Dr. Ngarina, just 2 minutes.
Thank you, Joseph. Good morning, everybody. Bado ni morning. Good afternoon. This topic is not an easy one. I think we've been in many forums and we've visited sites that have been procuring abortion. Tulikwenda na Makuani, na Joseph, Ethiopia, just to see, tulienda kwa lengo la kuangalia how did they manage to reduce the maternal mortality, and they said it's because they legalized abortion. And then we visited the sites where they do the abortion. Kuna mali tulipita, Makuani akasema, not during my time, hii kitu. Lakini I'm also practicing. There are cases that come to you, unaona kabisa this needs abortion. Hiyo najua hata kwenye nani zetu it's allowed. I have a very senior person ambaye she's her faith and her profession alikuwa anasema mimi I'll never go for this. And then her daughter got pregnant when she was in Form 2. And then the FICAT came now. What do you do? Do I leave her deliver? What do I do? And then mtu aliyempa mimba ran away. Kwa hiyo ghafla akagundua kwamba kumbe hata yeye anahitaji, japokuwa mwanzoni alikuwa anakuwa against it. Kwa hiyo it's something ambayo slowly, at least these days we are coming to a stage where we can discuss. It's a big step. Na polepole tunaendelea, mioyo inaenda kulainika, lakini it needs control. It's not that it should be allowed like that rampant. Kama alivyosema Marekani, hawa wanataka, hawa hawataki. Kwa sababu kila kitu kina uzuri na ubaya wake. Kwa hiyo maybe as we keep on discussing, we'll come to a point where wote tutaona kwamba okay, we do it, or how do we do it, or we don't do it. Asante sana.
So, Honorable Judge, asante sana Dr. Ngarina. Huyu ni rais wa chama cha madaktari wa wanawake Tanzania, ambaye kazi yake ni kuwahudumia watoto kila siku, akina mama kila siku anapoamka. Kwa hiyo sauti yake ni ya maana sana kwenye hii discussion. Mheshimiwa Judge, what is your comment to the questions which were directed to you? And when you answer those questions, please also tell us what you think should be the way forward from here.
Well, I'm not sure if there was any question directed to me. What I can say is some of the speakers only made comments, and I believe Tike as well commended me. Thank you for that remark. But otherwise, I believe there was no question direct to me. But if I'm mistaken, then you can raise your hand and give me an opportunity to respond to that one.
Maybe, Mheshimiwa Judge, if you may tell us, what do you think should be the way forward from here? You know, in realizing, full domestication of Article 14.
Well, the way forward. Tanzania ratified the Maputo Protocol without any reservations. And when you look into practice, you will see that our health practitioners, as said by Dr. Makuani, is that abortions are being done in hospitals. Now you have those abortions conducted in hospitals which have all the best equipment, taking into account various aspects of abnormalities of women and some other reasons. But the Maputo Protocol is bringing up a situation where a woman is being, say, raped, and it is not her wish to conceive. So what do you do with that? Do you leave this woman to torment throughout her life, to give birth to a child which does not have its father? Then this is where the challenge arises. Because when a woman gives birth to a child against her wish, against her will, actually that brings up something with respect to mental health. She'll be tormented, bringing up a child which the father is not known. So there are situations where you need to have guidelines, but of course guidelines on one side are for the practitioners, I believe so. It's not for the public. But if you put some of those in the law, then that goes to everybody. So if there's any problem coming in, as a practitioner, you will take benefit of that. Some of the provisions, especially Section 230 of the Penal Code and Section 219, are talking about conducting an abortion with utmost good faith. Now, this is where a room has been given to doctors to analyze the situation, to see what kind of they can do, either to save the life of a woman. Now, what the Maputo Protocol is bringing up is to expand what is related in the Penal Code. But again, as we have said, that if you put only those in the Maputo Protocol, you may deny other areas where such acts of abortion can be taken care of. So I would say this is still debatable, but at least we should come to an end of this. We've taken more than 20 years on this, and I think the moderator made a very good suggestion. Maybe we included the Maputo Protocol provisions and put a provision which will open other situations where abortion can be conducted. Thank you.
Asante sana, Mheshimiwa Jaji. We are now...
This is used, if you go within the protocol how to mitigate those challenges, I think there are ways of mitigating. Within the kit of GBV and REP, there is a way of preventing pregnancy. So that should not be an excuse of saying that tunataka tuweke hii provision kwa ajili hiyo. Hiyo naiweka tu kiserikali. Asanteni sana.
Okay. Kuna issues za access ya hiyo service ambayo mama anaweza kaitumia kama amebakwa haraka akapata hiyo huduma, lakini kama sisi tunaotoka kule vijijini inawezekana hata hiyo huduma isiwepo karibu. So jamani, naomba please join me for a big clap for the panelists. And also join me for a big clap for yourselves, for staying here. We are already 5 minutes ahead of time, so thank you so much for your attention. Thank you so much to the panelists. This was a great discussion, and I think to be continued. And also, I think you guys should have coffee, because it looks like you need to talk to each other, but you are not. Maybe because each one of us is working in different direction. Huyu yuko hospitalini, huyu yuko wizarani, huyu yuko mahakamani. lakini you can create an environment for sitting together, have a coffee, and have a good discussion. And Pathfinder would be very happy to facilitate that discussion among yourselves, together with CAMMAC. So in this discussion, we highlighted a lot of things. Number one, the judge told us that a lot is already going on from his office, and more to come. Different workshops have been done, different documents have been analyzed, so a lot is already going on. Another key point which we noted today, and I want to speak this loud, Tanzania ratified the Maputo Protocol without any reservations. Kwa hiyo, in a way, ni kama sisi ndio tumekwama wapi? Maana there is no reservations which the government put out there, So those are open to start, moving the talk actually in this particular area. Another point which came out clearly from the interventions here is that the policy environment has been improving gradually. Previously we could not have this kind of discussions openly, but now as technical people we can stand together, sit together and have a discussion about this topic, which I think is a very good advantage to have, and we can leverage that. We were warned by the medical people, especially from the Ministry of Health, that, let us be careful, let us not put a lot of pressure, because changing the law, putting some specific issue in the law may actually end up obstructing services. So SRHR advocates, please take that into your mind, so that you don't end up closing the doors which are currently open for service provision. Also, we learned that, the ministry has been progressing according to the technology. There are now medicines which actually are available, and people, especially those who are living in the rural areas where services are not really available, they can easily access medical post-abortion care or medical abortion using misoprostol, and hopefully soon with the mifepristone, which has been recently been registered. So thank you so much, at least for highlighting that. We are reminded that women who have undergone abortion for whatever reason, whether they induce themselves, whether it is spontaneous, should be treated with compassionate, without any stigma. Their rights should be respected. Madaktari na manesi, naomba hiyo mlisikie vizuri. Mama akija hospitalini kwenu, mimba imetoka yenyewe au ameitoa, apewe huduma yenye staha. Sawa jamani, tusianze kumbagua mama na kuanza kumsomea misahafu. Mama apewe huduma ambayo anastahili. Another thing, we learned about strategic litigation. Dada Walter, thank you. Kesi mkakati. And thank you for pointing out some of the examples of kesi ya Rebecca Juma, kesi ya Malawi, na kesi ya Kenya. And as you said, Tanzania is ready for that. So we wish you luck in that process. And please keep us posted. This issue of stigma around abortion was also very highlighted, both among service providers, but also in the community. And that's why we have these issues around values clarification, which we implement. Na jambo la mwisho ambalo ningependa kuliongea kwa Kiswahili ni issue ya values. Hata madaktari na manesi na wenyewe wana values, na wenyewe wanahitaji support inapofikia kwenye mambo magumu. Mambo ambayo ni magumu kuyadiscuss hapa, hata wao wanayaface wodini. Kwa hiyo na wenyewe wanahitaji support, tusiwaone kama wao ndio wanataka watu wapate mimba, au ndio wanazuia watu wapate mimba, au ndio wanataka watu wazitoe, nini hapana. They are constantly being faced by those challenges, and sometimes it affects their values. Therefore, issues around values clarification is very, very important for the service providers as well. And last but not least, let us sit together and have these discussions. Baada ya kusema hayo, nawashukuruni sana for your attention. I believe lunch is ready. Karibuni lunch. And we are going to take photos here with the panelists, 1 or 2 photos. Na wale ambao wangependa kuteki wale wajumbe wa CAMMAC ambao wako humu, vile tutawaomba baadaye mje mchukue picha na panelists wetu. Kwa hiyo picha ya kwanza ni ya panelist, picha ya pili ni ya members wa CAMMAC ambao wako kwenye huu ukumbi.